Hey everyone, we've got another specimen today. This is number 62 in our collection, and we'll start off by going through a quick teaser or preview of the main phenotypic features of this heart. And right off the bat, we'll see, at least externally, that there is a right-sided atrial appendage that appears to be tubular, finger-like, consistent with a morphologic left atrial appendage. And then we find that on the left side, we find a similarly small, tubular, finger-like atrial appendage as well, also consistent, at least externally, with a morphologic left atrial appendage. And when we look at the right-sided atrial appendage, we find that all the pectinate muscles are in fact confined within the appendage itself. And when we go over to the left-sided atrial appendage, we find the same is true there. So we do have isomerism of the atrial appendages. So we are dealing with a heart that has what appears to be left isomerism. When we look at the left-sided lung, it does appear to have two lobes, 1, 2. And then when we look at the right-sided lung, it also appears to have two lobes, 1 and 2. So we have two-lobed lungs. We've got two, at least morphologic, left atrial appendages. And then when we look at the trachea and the bronchuses here, we can see that there in fact is about an equal angle on both sides from the trachea to the bronchuses. So the tracheobronchial angles on both sides are in fact equal or symmetric, all consistent with morphologic left isomerism. So it seems like we're dealing with a heart with left isomerism, which is truly the main phenotypic feature of this heart. So now we'll go ahead and go through the rest of this heart. Heart would have sat in the chest like this, anterior surface towards the screen, posterior surface towards the turntable, head or superior here, legs or inferior here, left over here, and right over here. Now, here is the right-sided left atrial appendage. And we know that this is a left atrial appendage because when we do open it up, the pectinate muscles are confined within the appendage itself. And then here is the right-sided left atrium. So this is the right-sided morphologic left atrium. And we can see this is where the oval fossa would be. Here is the mouth of the coronary sinus. So this heart does have a coronary sinus. And remember, the coronary sinus is a left atrial structure. So certainly can be found in hearts with left isomerism. And then here is the tendon of Totaro. So here's the tendon of Totaro, mouth of the coronary sinus, and the right-sided atrioventricular junction. So the triangle of Koch, which is bounded by those three structures, would be right here. And its apex would be here, which is then where we would expect to find the atrioventricular or AV node to be. Now, when we look at this right-sided left atrium, we do find that there is a superior caval vein that drains into the roof of this. But interestingly enough, it also accepts another vessel. So this, in fact, is the azygos vein, which drains into the right-sided superior caval vein, which then drains into the right-sided morphologic left atrium. So we are dealing with a heart that probably had an interrupted inferior caval vein, and there is azygos continuation into the superior caval vein, which drains into the right-sided morphologic left atrium. Now, when we look at this right-sided atrioventricular junction, we find an atrioventricular valve with 3 leaflets, 1, 2, 3. There are direct septal connections consistent with a morphologic tricuspid valve. So here is the septal leaflet, here's the inferior leaflet, and here's the anterosuperior leaflet. When we go ahead and look at this ventricle here, we find that it does have coarse trabeculations. It does have a septomarginal trabeculation. And here is the Y of the septal band, consistent with a morphologic right ventricle. We also see that there is, in fact, an intraventricular communication here. There is a ventricular septal defect. There is some continuity, fibrous continuity between the tricuspid valve and the mitral valve that we can see here, consistent with a perimembranous ventricular septal defect. When we get to the right ventricular outflow tract, we come to our first arterial valve. It does have 3 leaflets, 1, 2, 3, with 3 sinuses, 1, 2, and 3 over here. This arterial valve is entirely supported by muscle, all consistent with a pulmonary valve. Now, as always, we'll note that look at the arterial valve. It doesn't actually have a true round or oval annulus. There are these semilunar or half-circle fibrous valvar leaflets that have these triangles interposed between them. Thus, the actual round or oval annulus for the arterial valve that we like to create by imaging isn't a true anatomic entity, but that doesn't mean that it isn't a helpful tool for surgical or interventional planning. There are no coronary arteries that arise from within the sinuses here, also consistent with the morphologic pulmonary valve. Here is the pulmonary trunk, and then here is the left pulmonary artery, and then back here is the right pulmonary artery. And we can in fact see that there is an arterial duct that appears to be patent to the aorta. Now we'll go ahead and flip this heart over. And when we do that, we see obviously the lungs, which remain attached to the specimen. And we now see the pulmonary veins. And we'll try to see where these pulmonary veins actually drain. And when we do that, we find that the pulmonary veins actually all drain back into this right-sided morphologic left atrium. So all the pulmonary veins drain back into the morphologic left atrium on the right side. So let's try to go ahead and find the other atrium. So here is the other atrial appendage. And now when we open up this atrium here, we find that this is also smooth-walled. All the pectinate muscles are confined within its appendage itself, also consistent with a morphologic left atrium. Here is the flat valve of the oval fossa. There does appear to be a defect or an intraatrial communication here, as we saw from the right. And once again, here are those pulmonary veins coming back from both the left and the right lung that drain not into the left atrium, or the left-sided left atrium, I should say, but in fact drain into the right-sided left atrium. And you can see how this left-sided morphologic left atrium appears smaller than the right-sided morphologic left atrium. Now, this right-sided morphologic, or left-sided morphologic left atrium does have a valve with 2 leaflets, 1, 2, that guards the left-sided atrioventricular junction. This valve does not have any direct septal connections consistent with a morphologic mitral valve. So here is the anterior leaflet, and here's the posterior leaflet of the mitral valve. When we take a look at this ventricle, there are fine crisscross trabeculations consistent with a morphologic left ventricle. And here we see the ventricular septal defect from the left side, and we can better see the continuity between the mitral valve and the tricuspid valve. So this, in fact, is a perimembranous ventricular septal defect. When we look at the left ventricular outflow tract here, we find another arterial valve here that has 3 leaflets and 3 sinuses. So 1, 2, 3 leaflets. Once again, note that the structure of this valve itself has these semilunar or half-circle fibrous leaflets with these interleaflet triangles interposed in between them. And so the arterial valves don't actually have a true round or oval-shaped annulus. There does appear to be some continuity between the mitral valve and the aortic valve here. And we find a coronary artery arising from within the sinus of this valve, all consistent with a morphologic aortic valve. And so here is the ascending aorta. You can take a peek at that from over here. So here is the ascending aorta. Here is the transverse aorta. Here's the descending aorta. And then once again, here's that arterial duct from the pulmonary trunk to the transverse arch. So here is an interesting heart with left isomerism, with then right-handed ventricular topology, concordant ventriculo-arterial connections, a patent arterial duct, and an interatrial communication, as well as a perimembranous ventricular septal defect, and pulmonary veins that drain back to the right-sided morphologic left atrium.